afternoon and welcome to yet another Karkandu session. I have great pleasure in introducing Mrs. Shanti. She is the Group Nursing Director of Cherry Care Hospitals, and Ms. Subhashini, she is the Group HR in charge, and we know each other for many years from Apollo days. Welcome, ma'am. Welcome. And actually they are in the process of organizing one nursing conference, so I said first you should see our small meeting, then you have an idea how we have interdisciplinary learning here. It's a very enjoyable day of the week for all of us. Every single patient that comes to the hospital will have some catheter inserted somewhere, and most of them will have a catheter or a line that gets into the bloodstream straight. And the chances of these line infections are pretty high. And as compared to the rest of the world, the catheter-related infections in India are higher, 4 or 5 times higher. And we all should understand that there are so many safety precautions that we have to undertake while introducing these lines and maintaining them to reduce the infection. And to do that, we have a set of specialists to tell us how to take care of these lines. Over to Swarna.
We have put together a very informative session, and now let's have the ICU team.
Good afternoon, everyone. Thank you for this Karkandu opportunity to present this presentation on catheter associated bloodstream infections. Myself, Dr. Arif, multidisciplinary ICU consultant. Thank you, Karkandu, for giving me this opportunity to present this very important topic, which is one of the important topic where most of the patient in the ICU, they have definitely a central line. Very less people only have peripheral lines, and they have almost in their body, almost everywhere there will be a line. If there is central line, we reduce the peripheral lines, of course. But still, infection rate, when we think peripheral lines or central line is very high with the risk of infections. So, what all we can do to prevent the central line infection, the strategies. Myself and my team, Akbar, a physician assistant in our ICU, will be presenting as well as demonstrating about certain steps, how to do the hand hygiene and steps and everything. So, where are the central venous catheter inserted? The access sites, if we see. First is the easiest one, what we see in the neck, that is internal jugular vein, and below that is the subclavian vein above the chest, and the other line is a femoral line. Femoral line as well as all the 3 lines, right and left side we can place. The important thing about how to choose a location for placing the lines is also very important. Another one more line is there, peripherally inserted central lines. That where we will place it is in the cubital region, in the basilic or a cephalic vein, which is a large bore vein. There is also another permanent veins that placement. That is one is a tunneled one. That for we usually use for dialysis patient and chemo on patient who is on chemo treatment. So in that case, where they will place the line? Mostly they will place in the subclavian. Why? The infection rate when compared to central in the between the central lines, infection rates when compared to internal jugular vein versus subclavian vein. Subclavian vein has a very less risk for developing infection, whereas in the IJV there are a lot of chances infection rates when compared to subclavian vein is little higher. And when compared to femoral vein, internal jugular vein is only having a very lower risk for developing infections. So we have to choose this site according to the patient necessary at the time and how the condition is. When the patient is very sick, it is difficult to place an central line in the IJV. In that case, we have to think of femoral line. And at that time, we cannot go and place for us subclavian line. It is still more difficult, and the situation can go a little bad. So to avoid all those things, and in keeping in the mind the risk factors, central lines will be chosen. WHO advises 5 movement while going around the bedside. One, we have to do always the hand hygiene steps before entering near the patient bedside. One is before touching a patient, and second, any procedures before that we have to do a hand hygiene. Along with that, in case of any exposure to any body fluids, definitely we have to do a hand hygiene. Along with that, before and after, that is while touching the patient and after touching the patient, along with the surroundings, even when we touch the touch and hold the bed side rails, we have to definitely have a aseptic precaution maintained. Whilst we are coming out of the around the bed, definitely hand hygiene should be maintained. So how to do the hand hygiene with the antiseptic? What is the antiseptic we are using? It's a chlorhexidine gluconate. It's shortly called CHG. It's more than 0.5% to 4% with 70% of ethanol in it. We use it for our antiseptic hand rub. How to do? I will be telling the steps, as well as Akbar will be demonstrating. Akbar. So we have to take the antiseptic sterilium, that is 4% chlorhexidine with the 70% of ethanol, a palm full of product in a cupped hand. How he is holding, that the same way. Then second thing, rub hands palm to palm. And then next is right palm over the left dorsum, and the vice versa, left over the right, same way. And palm to palm interlaced. And back of the fingers to opposing the palms with fingers interlaced. And rubbing of the left thumb with the right palm, and again the vice versa. And finally the clasped fingers in the palm of the left side and the vice versa. And finally allow it to dry. Whilst we have done it, our hands are clean and safe. The same way for surgical scrub as well, where we will be using until the elbow, but that will be done the first, and then all the steps will be followed. Finally the hands are made to be dry, then only the hands are clean. What all others, when we are touching a central line procedure, central line, when you are using a central line, what all we have to do? There will definitely we will be administrating drugs through the hub, holding the hub. So before that our hands should be clean. So what we need to do is this extension with the hub. This will be connected to the lumen there. We are seeing the open. We are seeing the catheter, which is with the extension with the 2 lumen. That is, at the end of it there is a hub. That's a one-way valve, so that we can have needleless administration for the drug here. So how to scrub the hub? That we have first we have to wash the hands. Whomever is going to administer the drugs, Akbar, first washing the hands. He has already washed the hands now with the 5 steps. Yeah, and then wearing a glove. Okay, he has worn the glove, and then using a alcohol swab, which is a sterile one, and holding the edge of the hub with the sterile aseptic precaution in a twisting motion for 15 seconds to be scrubbed before administrating any medication or withdrawing for a blood. This twisting motion, like when we squeeze the lemon, that way we have to rotate. That is the way for cleaning the hub. And after giving medication or withdrawing the blood, we have to flush with the saline, and then again scrub the hub. That is the same method. And then there will be a scrub, the hub stopper, where we can close the hub so that the infection doesn't transmit. Finally, discard the glove. This is the way to scrub the hub. This should be followed for all the patient before we administer any drug through the central line or withdrawing for the blood. For all reasons, we have to maintain the sterile precautions. Why it is, how long we have to scrub the hub? That is 15 seconds. This is an evidence base where the study was done in Johns Hopkins. It reveals the decontamination effectiveness of this of the hub with the 70% alcohol, where in the 5 seconds we are able to see there is a minimum infection present there, and in the 15 seconds there is absolutely, it is a clean, sterile. Then for doing any procedure, we have to wear the PPE. Personalized equipment which is available with us. One, covering the head with the cap, wearing a mask and a gown. In case of any contaminant area where in case of COVID where isolations are given, we have to wear goggles and N95 mask accordingly. So first, how to wear the scrubs and wear the wash the hands. First we have to wash the hands. First we have to our scrubs and shoe covers if required, and wash the hands and wear N95 or normal mask and cap, and put on the goggles, and after wearing the scrub and gown, put the surgical gown and then surgical gloves. After washing the hands, he dries with the sterile cloth and he leaves away without touching any surface. And he takes the surgical gown, which is a sterile, and he is wearing without touching anywhere surrounding, and asking the assistant to help to wrap the knot. He does not leave the hand outside so that to avoid any touching over the surroundings. And to wear the sterile glove, the assistant opens the glove and he wears with the sterile method. He leaves that in a sterile area. And he makes sure that he doesn't touch any surrounding. That is very important. After wearing the glove, cap, mask and gown, the important things that we need to keep in mind is that even we should not bring the hands below our hip and behind our back. Yes. So this is the way our PPE is worn. Thanks, Akbar. After doing all the procedures, placing a central line, sterile transparent tegaderm, which is a chlorhexidine gel, which is in the center where we can see here, which is demonstrated in the picture. This is a gel which is a chlorhexidine 70%, where it has been commercially available, so that to prevent the risk of infection entering extraluminally as well as intraluminally. So this is a transparent tegaderm where we can see whether if any soil, whether any bleeding or any soakage or any skin irritation is happened, we will be able to see through this. That's the advantage of this transparent tegaderm. This is advised to be placed after a central line is done. So how long we need to keep, how long we can keep it, and what are the methods that we should follow every day, is that every day we have to examine this area whether any small infection or soakage is there, or any redness is there. So we have to see for it. If in that case we have to, if necessary, we have to change, we can change it, or otherwise With the gel coating, which is a chlorhexidine present in it, we can change it 7 days. That is recommended. So these are the important things that we have to follow. One is hand hygiene, that I have explained to you with the 5 WHO steps, and then line assessment, where we are going to place it and how long we are going to keep it, and we have to reconcile every day whether the line is needed or not. And while using the central line, scrubbing the hub is very important. The method which we taught, that is to be followed with the sterile precaution. And what the medications when we are giving through IV tubings, that needs to be changed according to the medicine or products whatever we are giving. For example, if it's in a blood product, then we have to change it in 24 hours, or once the blood is over, we have to remove the IV administrating lines. Dressing needs to be changed as necessarily. When it is getting old, like, or any infection is that, definitely after every 24 hours we have to reconcile and change. Or this when it is clean, 7 days is enough. Securing the device, that is locking the hub with the blocker, and educating the patient about the lines, what is placed, whether it is a permanent one or a temporary one. We have to teach them how to keep it, as well as if they have any fever, signs of infections like fever or any other swelling or any pain around the site, we have to explain them so that they can come and tell us. Why are we all doing all this? Should be some goal of care. The important thing is to maintain a aseptic one. What is that aseptic? There's just a step which we need to maintain, so that a clean procedure is being done, and during the administration of the drug, as well as after using the line and everything, we have to maintain a sterile way, because catheter related bloodstream infections, which can make the patient more to be stay in the ICU, to avoid all those related infection through the line. We have to maintain this aseptic precautions by no touch technique or hand hygiene. That is, we are doing our hand hygiene steps and everything. No touch technique is that what all the products which we are using for example, the port, or while inserting the line, the needle tip, and the injection syringes at the male lower and the end of the syringe, those are all needs to be very carefully touched only with the aseptic precaution. In that case, if we are not clean hands, we are not maintaining a clean hands, we should not touch at all. For that only the aseptic no touch technique. And what is this colonization? Whenever we give drug administration or blood products, definitely there are going to be microorganisms going to harbor in the central lines, which in the longer days, when it is going to be continuously maintained, the colonization happens, and at one point of time when it is going to get infected, then they have going to have infection because of catheter-related bloodstream infection. To avoid that, wherever the catheter-related bloodstream infection in peripherally inserted catheters or centrally inserted catheter, both should be maintained in a well hygiene manner. Extraluminally or intraluminally, how does the infection enters? So in this picture we can see the skin layer, and catheter and the port is here. This area where the insertion has happened, where the needle is pricked, and the this area where the needle is pricked and the catheter is threaded here. This is where the extraluminal area. The intraluminal is where we give the drugs. The intraluminal contamination transferred to the hub from the environment when we give medications, when we give blood products, and if we maintain the hygiene, hand hygiene, and all the methods advised by the WHO, then this infection here, the risk of infections are reduced. Whereas extraluminal, while we are placing the central line, we have to make sure that the lumen is not left too much. If the lumen is left too much, there can be rubbing of the skin, and the mucosa can get damaged, and infection can create. So healthy mucosa should be maintained while placing a needle and while placing a catheter. So this is extraluminal contamination, and this is intraluminal contamination. This is the where we will see in the transparent tegaderm any site infection or hematoma or any irritations around the and if there is a longer length we can understand here. If it is an older, like earlier we used to have very not a transparent one, non-transparent one, which does not show us outside whether there is an hematoma or irritation or anything, where this tegaderms are advised to be used for these reasons, extraluminal, to avoid the extraluminal contaminations. This to avoid this to maintain skin anti-sepsis with the chlorhexidine 4%, and the dressing is definitely as a shield, where I showed you the tegaderm which is having a gel that is available with the alcohol and which is around 4%, 70% of alcohol and 4% of chlorhexidine in it. And that medication dressing will prevent, definitely there is an evidence which is showing that medication dressing prevents infection, and people having for catheters for longer days, they didn't had any much infection, because when they are used the medicated dressing. Device securement, while we are placing the catheter, it is very important that the central line is being made, the skin area preparation is very well maintained. While shaving, because of the hair has imported a lot of infection in it, so better, if it is not too much hair around the neck, better not to shave, because that itself harbor infection. So, and we have to make sure that there is no any skin irritation or injury happening while placing the line. This is extraluminal strategies that we can do for preventing infections. Intraluminally, that is I told you, while giving medication, we are not using any more needles. We are only using needleless connectors and hubs. That is all used with the hub scrub. I just show you how to do. And administration set, when there is a parental nutrition, when we are administering, we are only giving it for 24 hours, because it contains lipid and there is a lot of chances infections can go through the bloodstream. Another thing is lipid also, definitely any lipid form other than TPN, we are giving a lot of lipids. That also will have definitely infection process very high. So within 12 hours we have to change the administration set, IV sets. If we use sedation in ICU, mostly propofol is also a lipid emulsion. So that when the emulsion is over in the filled syringe, we have to change complete syringe as well as the administrating the lines also. For 6 to 12 hours we have to change. If it is earlier, it is getting over, we have to change it off. Flushing and locking with the saline lock is very important. Saline, that would be a sterile saline, not by taking a saline which is already opened out. That can harbor infection. Many times central lines are placed and used for taking blood sampling. In that case, discarding method only we will be using to avoid taking out whatever blood we are taking out from the line, the initial 5 ml or 10 ml, that we don't replace it back, we discard it off. Though there will be a blood loss, we cannot here the risk versus benefit is more important. For infections, we should not replace the collected blood in the syringe. So after blood sampling, we have to discard the sample and flush it with the sterile saline to avoid intraluminal specific strategies. These are the methods that we have to follow. One is hand wash, wear a sterile glove, aseptic field. While we are placing a central line, we have to make sure that sterile full sheet that should be placed, because one, the blood can be spill over, and second, the needles and the guide wires what we are using, that can extend up to the abdomen level. So full sheet should be always worn, and no touch technique, as I told you, the hub, scrub, rub and everything. The needle end, that should not be touched at all. Even we are sterile, unnecessarily we should not touch the needle end. And hand wash is a very compulsory at the end of procedure also, to safeguard ourselves. The important thing about the non-touch technique, these are the important thing. One is that key site, that is intravenous device. What are we are placing, what kind of type of catheter we are going to place, whether it is a tunneled or a non-tunneled. The other thing is the syringe tip and the male lower end and the spike of administer set. That is all very important. The injection syringe needle end and the administration set we should not touch. With all this, aseptic field should be maintained. That is, we should use a sterile tray procedures for procedures, and or a single use procedure kit or barrier, whichever is available, we have to use it, not a unsterile one. And a sterile draper, that I told you, a full sheet when we are going to place a central line, as well as a micro critical aspect field, that is whenever we are using an ultrasound machine, then we have to use a sterile glove, that is sterile covers and sterile caps in case of any important procedures we are going to do it. What finally we have to see is that every day we have to think of whether this catheter is needed or not, catheter dwell time, how long we are going to keep the time, we have to, every day we have to assess with either with a peripheral or a central or a permanent. Temporary is what we are using in the ICU. Permanent is which is related to chemo port as well as dialysis catheter. Thank you very much. Akbar will demonstrate you how to place a IV line in just a few minutes. Yeah, yes, sir. We'll do that. Volunteers also welcome.
So hello everyone, myself Akbar, physician assistant from MDCCU team. So I'm going to tell some points about how to do peripheral venous catheterization in a sterile way and how to prevent unnecessary infections. So peripheral venous access is the very common vascular access we are doing in a hospital setup as well as pre-hospital setups for various uses. It starts from administration of IV fluids, administration of IV drugs, transfusion of blood and blood products, and for venous sampling also. Catheter-related bloodstream infection due to peripheral lines is actually comparatively low when compared to central lines, but if we don't care the peripheral lines properly, it can cause serious bloodstream infections. Let's see what are the importance of sterilization before doing peripheral cannulization, and what are the daily care we need to do. So why sterilization is important? So because we have natural flora, skin flora, so that is nothing but presence of microorganism on our skin naturally. Examples are Staphylococcus epidermidis, Staphylococcus aureus, and Candida species also present on our surface of skin. So these can be infectious when they enters into the bloodstream, and we have to do this effective sterilization. To prevent this, we need to do a proper sterilization. How to do a proper sterilization? As Dr. Arif sir told, we need to use 2% chlorhexidine solution at least plus 70% ethanol. So we need to sterilize the area in a circular motion from inward to outward. At least we have to give 2 to 3 inches of radius. So next one is contact period, something called contact period. So that is a minimal time we have to give to the sterilizing agent to dry. So then only we can get maximum sterilization effect. So at least we should give 30 to 40 seconds. Fourth one is do not touch again. If you sterilize the area with chlorhexidine solution, we should never touch again. Do not keep IV cannula on bed. So we usually some people do that, they will remove the IV cannula and keep on the bed. After that only they will search for veins. That is very bad thing. We should not follow that thing. Why? Because bed is a super source for infections. So all the microorganisms are there. So because our patient is defecating there, our patient is urinating there, vomiting, he is multitasking there. So we have to we should not keep any sterile objects on the bed. So what are the daily care? We have to wash our hands before and after using the ports of the peripheral lines. Next one, sterilizing the hub before use. As I have already demonstrated, we have to do take a alcohol swab and sterilize the area for about 15 to 30 seconds at least. If we happen to see any oozing out or blood clot at the insertion site, so we have to use, more importantly, we have to use jelly tegaderms or transparent tegaderms so that we can find any redness, swelling or any oozing out blood clot around the insertion site. So blood, we know that blood is the super source for infectious organisms to grow. So we need to immediately remove the tegaderm and we have to sterilize that with the alcohol swab completely. Wait for a few seconds. If there is any active oozing out, if there is no active oozing out, we have to take a dry gauze and again sterilize, clean the area and put a new tegaderm there, the transparent tegaderm. So reassess of necessity daily. So daily we have to reassess the necessity of lines. Not only peripheral lines, we need to make sure that we visit like nasogastric tube, peripheral catheters, central lines, and Foley's catheter. We have to reassess for the necessity daily. Finally, we have a VIP score. VIP score is nothing but visual infusion phlebitis score. It is a score which shows the early signs of phlebitis in patients with peripheral cannulas. So the maximum score is 5. When I will give a 0 score to the patient if the line is completely working, there is no swelling, redness, anything. I will give 1 point when the patient is having redness or pain during administration of any drugs or IV fluids. I will give score 2 when the patient is complaining of pain, redness and swelling. I will give 3 points when the patient is having all the above complaints along with the indurations. I will give 4 points when the patient is having above mentioned complaints along with the palpable venous cord. Finally, I will give 5 points to the patients if the patient gets 4 points along with the fever. So these things we have to check daily. Thank you so much.
Thank you, ICU team. We are behind time by 10 minutes. We'll have hospital infection control nurse, Valarmati sister, for the next session.
Good afternoon to all. I am Sister Valarmati, infection control nurse. Many of them knows. I am going to talk about how we are controlling our central line associated infections, bloodstream infections. The guidelines, what we are following here, the definition is an intravenous catheter that terminates at or close to the heart or in the one of the great blood vessels that is used for infusion, withdrawal of blood or hemodynamic monitoring. These are the criteria we are using for the central line associated infections catheters. The following great blood vessels are considered. Aorta, pulmonary artery, inferior vena cava, bronchocephalic vein, internal jugular vein and the subclavian vein, external iliac vein, common iliac vein and the femoral veins. Devices not considered atrial catheters unless in the pulmonary artery, aorta or umbilical artery, atrial venous fistula and the graft, the atrial catheters also known as the transthoracic intracatheter. These are the areas, the lines are there now, we won't consider as a central line associated infection. This is the CDC guidelines. These for CLAPSI, we are divided into 2 groups. One is insertion bundle complaints and the second line is maintenance. So as I explained about the central line insertion and the maintenance process. We are monitoring the 2 lines. These are the things that we are educating our employees to avoid all the situation. For maintaining these kinds of bundle complaints, we are in the 0 level of CLAPSI rate. For surgical hand washing, already Muhammad has explained about the surgical hand washing that they are following in our hospital. For that, second is to minimize precautions for wearing gown, cap, mask and mask, that's all. The sterile drape, the patient to be covered with fully Fourth point in the prayer insertion, alcohol chlorhexidine only we are using in our hospital. Everywhere the solution is used, and disinfection is to allow to dry before inserting the line, central line. Central line is to be sutured properly after the insertion, and the cover of the insertion site is to be transparent dressing. We have two dressings in the transparent dressing. One is gel dressing and second one is plain. Just show that. The gel dressing, if they are using for gel dressing, this can be used for 7 days purpose. This plain one, we can use it for 4 days, 3 to 4 days. For CRBSI cases and all, this can be used. And after the insertion, date and time to be pasted in the dressing material, because after that only we can consider to be changed this dressing. 2 operators for insertion, because one person will be insert, the second person will be assisting, and the HAPCAR they will continue. For maintenance bundle, to assess and document the central line daily for seeing the lines, checking frequency of line checking, and any source of infection, any leakages, they need to monitor. Why they are continuing the central line, they need to monitor the documentation during our maintenance bundle. Second thing is hand hygiene to be performed before touching the line. Then after hand hygiene, they need to wear the sterile gown. Sterile gown means they cannot use the sterile gown, they can use for the hand care, for continuing antibiotics. Promptly remove unnecessary line to be removed. And the ports are using clean technique. Sir has explained already, we are before giving any injection, the port to be cleaned with 70% of alcohol swab for 30 seconds or 15 to 30 seconds in our duration, because the port to be evaporated or the dry. To keep all the port capped when it is not used. Ensure the stopcock are visibly clean at all times. There are blood stains in the, please remove it and reinsert it. Empty site to be covered with transparent dressing for checking of redness, discharges and inflammation. If present, they need to remove that line. And the 8th point is to use alcohol based chlorhexidine to clean the central line site before changing the dressing. I told you, after 7 days we need to change the dressing. While changing the dressing, they need to use the chlorhexidine solution for cleaning the site of the central line. Allow that while cleaning the site, the disinfectant solution to be dry. At that time we need to wait. The dressing to be changed if loosened or it's solid or compromised, we need to change the dressing. Use pre-filled syringe for flushing purpose. If the line is not used for long, more than 6 hours, we need to flush. Change the IV tubings. For continue IV fluids, they need to change the IV tubes for 48 to 72 hours. They need to change. For that, we are putting our label in the IV set itself. For Sarah has already explained, the concentrated solutions we are using for 6 hours duration. We are changing all the lines. Then we need to educate the patient how unavoid unnecessarily touching the line. For this, these are the maintenance bundle we are following in our hospital. For that, our CLABSI rate is 0 so far for past 6 months. 0 rate. Yes, sir. We are following. I am doing audit. Sir. Yes, sir. For criteria, what criteria we are using for this? The laboratory confirmed the bloodstream infections. We got the report from the laboratory. We need to see the length. It's more than 2 days of calendar days. If the sample are sent, the patient sample are sent, the source is more than 2 days la irundhudu. The event of patient is developed fever, chills or hypotension. These are the source irundhuchana, the sample are sent, the source is positive na, it's a criteria fit. The same time we need to send for 2 sets of culture the same time, central line and peripheral line. Anybody, why we are sending for 2 sets of culture? Any reason? Central line எடுத்து அனுப்பினோம்னா the growth will show சீக்கிரத்தில், பெரிஃபரல்ல லேட்டரா வரும். பெரிஃபரல்ல வந்துச்சுன்னா 100% central line associated infection. பெரிஃபரல்ல வந்துச்சுன்னா the patient is sepsis. For that we are sending for 2 source of cultures. This criteria பார்த்தீங்கன்னா central line insert பண்ணாங்கன்னா பண்ணி 3 daysல ஏதாவது சோர்ஸ் இருந்து சாம்பிள் சென்ட் பண்ணி அது கல்ச்சர் பாசிட்டிவ் வந்துச்சுன்னா 100% CLABSI. central line remove பண்ணிட்டு within 3 daysல the patient developed any signs of fever, chills, hypotension, the sample was sent and the sample shows positive na, that's CLABSI. These are the criteria we are following in our hospital. Our rate is so far 0. The central line days are there. Any doubts, anything you can ask. Please follow the insertion bundle care and the maintenance bundle care. We are following. Thank you.
Thank you, sister. We next up have a demonstration from Vinayak Enterprises.
Good afternoon, everyone. So we represent Vinayak Enterprises, who is a leading medical supplier of disposable instruments. It's a 100 crore company where we have been supplying to all the corporate as well as government hospital, and we are one of the leading supplier from MGM group of hospitals. And today we thank Dr. Radhakrishnan sir for giving us an opportunity to introduce a new product in the market, which is a exclusive feeding pump, which has feed and flush advantage, which comes with a dual bag. So we'll just take 2 minutes, sir. So there we use the enteral feeding, and we use the Riles tube or the NG tube or the NJP. We have different types of feeding tubes available, and also there are some infusion pumps available, feeding pumps available. But this product is the brand name is called NutriCare, and this has been exclusively designed to deliver only the enteral feed, where most of the enteral feed or the feeding pumps you would have seen, it comes with a single bag. Whereas here you can see it comes with a dual bag, where one bag is exclusively designed for feeding, which comes with a purple color, which is a universal color coding for feeding, and the other bag it's for flushing. So where you can use water or saline, whatever the hospital protocol says. So once we connect the feeding pump with this bag, so you can see here it is very simple to use. So there are 2 channels available here. So we can fix the slots and then extend the feeding tube and fix it in the another slot for feed. Bottle. And as I said, it is very easy and simple to use. The first and foremost advantage of this pump is, as I said, as the feed, so we need to key in whatever the parameters. So suppose 50 ml per hour or 100 ml per hour, we need to set the feed rate, and followed by that the flush, whatever the flush rate we can set it. So once that is set, automatically whether the intervals also we can set, whether it is every 15 minutes or 30 minutes or 1 hour. So the feed will start. Once the feed stops, the flush will start. So there is no manual intervention or a nursing intervention is required, and the display is also always on. So even from a distance also the nurses or the technician can easily visualize what is happening, whether it is not working or if there is any occlusion. If there is an occlusion, there will be an alarm. At the same time, so before starting the feed, see, as all we do for the IV devices, any administration sets, we do need priming. So here it is called purging. So when we so once we set the feed rate as well as the flush rate, we can start the purging, where automatically the priming will start. So if you want to do a manual priming also, that can also be done. So there is a stopper in between the 2 tubings. You can see the white color stopper. So once we switch to feed, the stopper will hold the flush tube. Once we shift to the feed tube, the stopper will hold the flush tube. So alternatively, it will work. So by that way, the feed and flush will be continuously on. There is no any intervention required. At the same time, this is not only the feed and flush advantage of this pump. There are other three advantages of this pump. The second biggest advantage is comes with a warmer feeding tube. So the warmer feeding tube, what it does is, see, if the feed is going to be cold, or then the normal time the feed will be like available when the kitchen is working. When the kitchen is not there, or the patient comes in late evening, the feed need to be started. So you might have a cold feed. So this warmer feeding tube converts the cold feed into room temperature. So again, it's a unique advantage of this pump. And third biggest advantage is we have seen it working in the gastro ICUs, where if there is any, the patient is having some bloatedness, some air in the stomach. So you want to remove the air alone. There is a decompression bag available which removes the air alone. And of course, it comes with a filter which will decontaminate the air and doesn't contaminate the atmosphere. This is the third advantage. And the fourth, but not the least, there is a back pumping option called back pumper. There is an option in the pump which allows, again, to remove certain gastric fluids from the patient's organs, whichever the volume we set and whichever the time we set. So this is the fourth big advantage of this feeding pump, and the brand name is called NutriCare. So any queries? So in fact, we can keep the pump for demonstration or evaluation in the respective units we want to keep. So since the time is short, so any queries you can ask. Okay, sir. Okay, sir. Thanks for the time, sir. And we do have an exclusive feeding tube range also, sir, from a company called Medicina, which is being imported from Italy. And the advantage there, it is made up of polyurethane tube and can be kept for 90 days, sir. Thank you very much. Thanks for the opportunity, sir.
We'll have the chemoport care session by Dr. Sumar Kalyan, sir.
ICU ECMO, not RF ECMO. So ECMO, so there is an European Society for Medical Oncology, ESMO. ESMO recognizes and give this degree. I got it in Madrid. So it is ESMO certified medical oncologist. Hello everyone. You want me to hold this? Yeah. No, that's fine. So which is the most costly of all presented today? Mine. Yeah, chemoport. But which is the most cost effective? Mine. Why? Because chemoport can stay for 5 years. So 5 years. So this costs about 30,000 and procedure everything, let's say 50,000. For 5 years, if we calculate, then per year it is 10,000, which is lesser than Venflon, right? So cost effectiveness is different from cost. You can just look. Preaching na 30,000 katnu. So these are chemoport needles. Yeah. Have you seen anyone using chemoport? Yeah. That's fine. So I'll take 10 minutes. Yes. So regarding chemoport, I already told the main important thing, but why do we need chemoport? These are learning objectives. Why chemoport? Chemoport handling for you, risks and complications, and I will evaluate. Every time I will evaluate. So why chemoport? This is our patient only. Our patient. What happens when you use IV lines for a long time in chemo patients? So the lines, lines kammiya da irukkum chemo patients. Yeah. Because if patient has breast cancer on one side, we don't use that side. Yeah. We use only one arm is available, and then every time chemo we put, that vein will become black. We cannot use it. Yeah. So I use panuma. What is this? What has happened? Extravasation. Ungalikku extravasation, ICU ku engalukku vera. After extravasation, what happens is thrombophlebitis happens. Yeah. Most of our drugs are vesicants and irritants. So they cause necrosis. We sometimes have to take a surgeon's opinion to necrosis la edukkuradhukku. So that's why we put chemoport. Where do we put chemoport? Here chemoport. Not in the center, but to the side. The tip of the chemoport, why I showed this is that most important point of part of chemo port will be in the center. The tip of the catheter will be inside the heart, right atrium varaiku pogum. Okay. What is this girl showing? Lady? My patient only, not from here. Hickey? No. Chemo port will look like this. There won't be anything outside. Everything will be inside. You put it inside and close it. So just see a bulge. The bulge will be the size of a bottle moody size. Just thottu paatha. So how do you use chemo port is, yeah, this is how it looks on an X-ray. It will be on the side, but the tip you see is near that Sri Ramar site, in the center. Okay, so tip of the catheter. This is the tip of the catheter, not this, not this. This is just the port that we use. Tip is almost into the heart. SVC and heart junction, the tip will land. So this is how we put it, which is out of syllabus. You don't need to put. Dr. Venkatachalam will put. But then what you need to know is, unlike other devices, you don't have to pump or push. It's just one silicon top will be there. It will be very, very soft. Just push the needle. I just showed the needle. I think you have the needle. You don't have to control anything because it's already controlled. It will be in the shape of a, right angle. So ரொம்ப அழுத்தமாக கொடுத்து சம்பளமே பத்தலைனாலும் எவ்வளோ நீங்கள் தரனாலும் அவ்வளோதான் போகும். So after that it stops. So just put the needle and plaster it. This is PICC line. I think Harry has already explained you. I'll just skip. And what is that lady doing? All are our patients. What is that? Hep lock. What is hep lock? Yeah, flushing. So we do a special flushing called hep lock. So what do we do is, and the needle unga kaiyila irukke, I have given you. So put that needle and draw blood. So once blood comes, that means it's still online. And then you give saline and then a hep lock and then connect it to the chemo port. As simple as that. This is the needle. I think you're having it, or I am having it. Okay, it's in circulation. So this is the needle. It's called a Huber's needle. So this Huber's needle we use. You can see that kink here. So that it's controlled, sir. Otherwise we go beyond the silicon. இங்கே விட்டு இங்கே எடுத்துருவாங்க சார் நம்மளுங்க. அதனால there is a control so that even if you push more, it won't go beyond the silicon pouch. Sorry. Yeah, so you can see that you hold through that yellow thing and then just push. இதை புஷ் பண்ணிங்கன்னா இவ்வளோ லென்த்து தான் போகும், அதை தாண்டி போகாது. So I think I'll skip the video. This is a video showing so many devices. I think most of them were demonstrated by Arif, how to wash, how to be clean, all that. So I'll skip. This is for pediatrics. For pediatric it's very, very cumbersome. You have to have all these devices, insert it, sterile precaution, all that. What you do in the ward is only this. This is also my patient, but from another country. Sir, I lived in a place called Miat. So what you do is first you drape and sterilize the place. Just a cotton swab is enough, and then take another cotton pad, put it there. Take the needle. See how she is holding. And insert it. Take one deep breath. That's very important. Plaster it and start. Yeah, she's drawing blood and then flushing and connect it to the needle. Every day you need not flush. So once the patient comes for the next cycle, you need to flush. But if it's a subsequent day, next day, next day, 3 days chemo, you need not flush. Just aspirate blood, see if it comes, and then connect it to the chemotherapy. That's all. 10 seconds will take. So these are risks and complications. Any device, infection is a risk. Migration, this catheter may migrate into the heart. That has happened. Catheter disconnection, catheter may disconnect, and then occlusion. All of these are surgical complications mostly. But what you will come across is infection, of course. Other one, practically, when you use a chemo port. Correct? Withdraw பண்ண பிளட்டே வரலடி இல்லையா? பிளட்டு வரலப்பா, என்ன பண்ணுறது? அந்த ஆளுக்கு ஃபோன் பண்ணீங்கன்னா அந்த ஆள் ஃபோனே எடுக்க மாட்டார். சுமன் கல்யாண் நைட்டு ஃபோன் பண்ணி எடுக்க மாட்டார். என்ன பண்ணுவீங்க? ஸோ ஐ டெல் யூ வாட் டு டூ. ஸோ பிளட்டே வரலைக்கு என்ன பண்ணலாம் அப்படின்னா, change arm position. Ask the patient to change arm, because what will happen is a fibrin clot will be formed at the end of the catheter, so it will act like a valve. So when you change the position, the clot will be released or it will migrate, so that it becomes most of them 50% of the time this simple maneuver. In the side la neenga catheter use pannirீங்களா அந்த side just ask them to flex the arm, then it will clear. Other thing is Valsalva maneuver. What is Valsalva maneuver? That one. Many people won't accept. அதெல்லாம் முடியாது, சும்மா இருங்க, வலிக்குது எனக்குன்றாங்க. So then what you do is ask them to take a deep breath. So when you take a deep breath, what will happen is negative pressure will build in the chest. That will release the clot. So these are very simple things, but very practical things. இதுவும் பண்ண முடியல, என்னால் ஒன்றுமே பண்ண, எங்கள் ஆளுங்களாம் அப்படியே இருப்பாங்க, இந்த கீமோ பேஷண்ட்லாம் நாங்கள் ஒன்றும் பண்ண மாட்டோம். Ask them to cough. So that will also build negative pressure. It will change the pressure in the chest, so back flow blood வந்துடும். கீமோபாட் ரிமூவல் போகிறது தான் ஈஸி, எடுக்கிறது ஈஸி இல்லை, அவ்வளோ கஷ்டம் இல்லை. ஜஸ்ட் புட் எ நிக் தேர் அண்ட் ரிமூவ் இட். லவ் பண்ணுறது தான் கஷ்டம், பிரேக்கப் பண்ணுறது ஈஸி. So chemoport removal is very easy. Dr. Venkatachalam will do it. We already have done about 17 chemoports here after I have come. So it's very easy, 5 minutes. Evaluation. Which of the following is considered oncological emergency? Neutropenic fever. Why not cancer death in ward? Death to ward like emergency இல்லையா? எனக்கு emergency இல்லை. Death is death. Already done இல்லையா? That's not an emergency. Right? Massive malignancy not an emergency. Cancer pain not an emergency, even if it's scale 9. So only emergency is neutropenic fever. That's why we talk so much about infection today. What is the main advantage? Enango? Is it easy to administration? No, it's not easy. No need for anaphylaxis, wrong. Does it reduce neutropenia? No. Yeah. B. So avoids repeated peripheral IV pricks. Where is the chemo placed? Anginator. Yeah, in the chest wall, connected to a central vein. Very good. So what is the most important nursing action when a patient develops febrile neutropenia? Antibiotic, Valarmadi. CT. So, yeah, don't wait for anyone. You can start straight away. You can start antibiotic. No need to ask anyone. Start meropenem. So I am giving you all the license. When a patient comes with the febrile neutropenia, means fever, already neutropenic, just start antibiotics. You can take the call. What is the most important nursing care step after assessing chemoport? Flushing, yeah. Flushing with normal saline and heparin. How do you do a heplock? Heplock ni yargane vaila varudhu. Appadi illana? Heparin, how much heparin? 100 units per ml. So you take 500 units, put in 500 ml saline. That is heplock. 5 ml saline, sorry. Which is the following complication of chemoport? Hair loss, ah? B team na romba pidikum. Yeah, port infection, right? Port infection is the most common complication of chemo. That's why we spend so much time on infection. Have you learned why chemoport, how to handle chemoport, risks and complications, and we evaluated. Finished in less than 8 minutes. Thank you. அது நம்ம தனியாக பேசிக்கலாம். So maximum of 5 years you can keep. So mostly chemoport we use for leukemia patients or kids. So they live. The cure rates for kids with leukemia are 70% now. So they live hopefully. Any other question?
For the final session, we have Arfa Sana for dialysis port care.
Good afternoon, everyone. I am Arfa Sana from the Department of Nephrology as a dialysis technologist. Thank you so much for giving this opportunity to present here. And now I am going to talk about dialysis port care. So first of all, what is dialysis catheter? A dialysis catheter is a medical device used for assessing the bloodstream in patients undergoing dialysis. So dialysis is a treatment for kidney failure that helps filter waste products and excess fluid and urea, creatinine, like that kind of toxins from the blood when the kidneys are no longer able to perform these functions effectively. And typically, dialysis catheter, it is a wide bore central venous lines with two lumens for drawing blood to the dialysis machine and returning the cleaned or filtered blood to the patient. So dialysis HD catheters, HD means hemodialysis, okay. So hemodialysis catheters are of two types, is acute and chronic. So acute is short term, that is non-tunneled catheter, and chronic is long term, it is a tunneled cuffed catheters. So it's a structure. Double lumen catheter, one lumen for blood flow is going on the dialyzer and one for inflow to going back to the patient. So catheter is made up of silicone or polyurethane for flexibility and durability. So most of common sites for catheter, it's internal jugular vein, preferred for emergency basis. It should be duration வந்து 3 weeks, மேக்ஸிமம் 3 வீக்ஸ்க்குள்ளே தான் வந்து இருக்கணும். அது கத்திட்டர் நமக்குள்ளே, அதுக்கு மேலே போச்சுன்னா வந்து அது ரிமூவ் பண்ணிடணும். ஸோ ஃபெமரல் வெயின் கத்திட்டர் அண்ட் சப்க்ளேவியன் வெயின் கத்திட்டர். ஃபெமரல் வெயின் வந்து மோஸ்ட்லி 4 to 7 days தான் இருக்கணும். தென் சப்க்ளேவியன் கத்திட்டர் இஸ் டியூரேஷன் இஸ் 1.5 months only. ஸோ இண்டிகேஷன் ஃபார் ஹெச்டி கத்திட்டர் யூஸ். Patient who have AKI, CKD and other emergency conditions to prefer to immediate dialysis, then you should use HD catheter for emergency basis. The new patient awaiting placement of fistula or graft or maturation or healing of fistula or graft. So established patient with failed fistula or graft, then a patient who was waiting for living donor transplant within 1 month, they should go for temporary catheter. Severe peripheral vascular access disease like vasculitis, or if no vein will find for emergency basis, temporary catheter will be preferred. So peritoneal dialysis patients requiring a short-term course of HD therapy, then they can use HD temporary catheter. So if any dermatologic conditions like scleroderma, you should go for permanent or temporary catheter. In pediatric conditions, patients do not have sufficient blood vessel size, so you should go for HD catheter. Or no toleration for longer nails, you should go for HD catheter. HD catheter care. Dialysis catheter care will start before inserting the catheter. So dialysis healthcare workers or nurses, practice workers should assist the physician and remembering the proper aseptic procedures and handling universal precautions. Physicians are pre-planned to put HD catheter, then advise to the patient to groom the hair, shave the beard, and bath with 70% alcohol content bath with chlorhexidine or betadine bath. So HD catheter insertion steps. First step is hand hygiene, mostly 3 to 5 minutes hand wash, wear head cap, surgical gown, mask and gloves, and then use central hole towel to the patient. It should be covered head to toe. Then sterilizing the patient with chlorhexidine or betadine solution. A USG guided catheter insertion with probe camera cover will be done with proper aseptic procedures. After catheter insertion, a proper non-occlusive dressing should be done. It should be transparent. How the healthcare worker will perform HD catheter connection, like as a dialysis technologist, how it will be perform HD catheter connections. So dialysis healthcare worker will perform dialysis with sterile and aseptic procedure manner, and as per CTC guidelines, healthcare workers should wear mask, perform hand hygiene, put in clean gloves during initiation. During dialysis initiation, clamp the HD catheter first and remove that catheter hub caps. So scrub catheter hubs with antiseptic like chlorhexidine and betadine solution. Allow hub antiseptic to dry. Connect catheter to blood lines aseptically. And then after that, remove gloves and perform hand hygiene. And at the dialysis termination time, same process will handle, but every dialysis, new catheter hubs will be changed in our dialysis. After the proper catheter lock should be done, it may be heparin lock or citrate lock. So dialysis port care. Dialysis port care is crucial to avoid infections and ensure that the dialysis. No, sir. Sorry. So, and ensure that the dialysis treatment goes smoothly. Then there are different types of dialysis access ports, including arteriovenous fistulas ports, AV grafts, and dialysis catheters. So the care for each type of port has some common elements but has unique consideration. So general guidelines for catheter port care: wash hands thoroughly, inspect the site, the catheter exit site. Regularly inspect the port and surrounding area for signs of infection such as redness or swelling, pain or tenderness, drainage or pus, increased warmth in the area. Cover the keep the area clean. Cover the port. Avoid tight clothing or pressure on that catheter site. Avoid water exposure. So, what dialysis catheter? Caring for the catheter. If you have if the dialysis patient have a catheter, that the insertion site will with antiseptic wipes with tea bactam ointment before each dialysis session, and keep the dressing intact. So avoid tugging or pulling that catheter. So how could we educate patients for HD catheter care? We should educate the patient, avoid touching the catheter site, avoid shower bath, towel bath only will preferred. They may be allowed to shower with a waterproof covering or bandage, but they should follow the recommendations for the healthcare provider for the specific case. We should use a cath shield cover for bathing. Not to allow the catheter wet. In case of bleeding, pains, chills, fever, should inform to the specific nephrology physician. If the dressing becomes wet, loose or dirty, emphasize that the dressing should remain clean, dry and intact. So no pulling or tugging, limit pressure. That's it. Thank you. Thank you. So this is a HD catheter. We mostly used in our actually I can't open it. It should be like this. Okay, thank you.
Thank you everybody for waiting up until the last. I know you're all excited for the quiz. I guess we can finish it if we start now. It's going to be quite an easy quiz. Which nutrient is important to help maintain skin and mucous membranes during cancer therapy? One of you please put your hand up. Anita sister, what is the answer? Yes, sir. What is the answer, sister? Sorry, vitamin A is the answer. Okay. Next question. BRCA gene mutations increase the risk of which type of cancer? Breast and ovarian, or skin cancer, lung cancer, or prostate cancer? Which one is it? Yes, doctor. That's the right answer. You can remember it with the BR. It's so that makes a clue. Quite an easy question. The HPV vaccine helps prevent. If you blurt out the answer, no prize for anybody. And not for the OGT. So I'm very glad that you know this answer, because it is important that HPV vaccine is administered to females. So nobody gets the prize? Sorry. Yes. As the ID specialist rightly says. Cervical cancer. Which virus is linked to liver cancer? Which one is it? Hands up and I will give you a prize. Yes, sister. Your name, please? Yeah, that's the right answer. Next question. Which of these is a common symptom of leukemia? Unusual bruising or bleeding, hair loss, loss of appetite, or altered bowel habits? One at a time, hands up please. Do you know what's the term that's given for it? No idea? It's called purpura. That's the right answer. You can take the prize. So please do the honors. Since all questions were easy, this one I put it a little bit tough. Which cancer is most strongly linked to asbestos exposure? Is it mesothelioma, leukemia, breast cancer, or colon cancer? Any nurses, please try. Krishna, any sister? Okay. Mesothelioma is the right answer. Back to the easy ones. Which month is observed as Breast Cancer Awareness Month worldwide? It's fast approaching. Yes, that, brother. Your name, brother? From the OT team. October is the right answer. It's called Pinktober. Next question. Which cancer is called the king of cancers because of its high mortality? Pancreatic cancer, brain cancer, stomach cancer, or liver cancer? Look at the clue. There is a clue on the screen. Kindly look at this. Look at the clue. I'll give to Ramya this time. Yeah, that's the right answer. Steve Jobs had pancreatic cancer. That was actually mentioned in Dr. Suman sir's lecture last week. So if you had listened, you would know. What is the leading cause of preventable cancer deaths worldwide? Is it tobacco use, air pollution, alcohol use, or obesity? No, hands up. You already gave out the answer. So no prize for this question. It's tobacco use. Lung cancer is one of the preventable cancers. Which type of cells are affected in leukemia? No answer blurting. I will keep skipping the questions if you blurt out the answers. Can anybody put your hand up and give the answer? One of you? You, sister, your name? What's the answer? Yeah, white blood cells is the right answer. Thank you, that's been my time.